Rank 1, the medical student. Most people who decide to become a neurosurgeon make that decision in a single moment they'll remember for the rest of their career. You make yours at 7 a.m. in the morning watching a stranger open a skull. Third-year medical student, neurosurgery rotation. The case is a craniotomy, the bone removed, the brain exposed, the attending working with a precision that doesn't look like effort. It looks like certainty. You're watching on a monitor. You don't breathe differently. You don't move. You just decide. What follows that decision? 14 years. Somewhere north of $300,000 in debt. A relationship that ends quietly in year 2. A mentor who will become the most important person in your professional life and who you will one day be forced to destroy not out of malice, but because you won't have a choice. And a version of yourself standing in this observation room right now that you will spend the rest of your career trying to remember. You're 23. You feel certain. That's the most dangerous part. Rank 2, the intern. 3:45 a.m., the neurosurgical ICU. Your pager goes off and you've been awake for 21 hours. You make $62,000 a year. You work up to 80 hours a week. Break that down and it comes to about $14 an hour, less some weeks. The overnight security guard downstairs makes more than that and goes home at 7 a.m. without anyone's life depending on his next decision. Your job right now is not to operate. Your job is to manage the margins of other people's operations. Hourly neurological checks on ICU patients' pupils, movement, response to commands. Overnight admissions, paperwork, calls from floor nurses about patients you've never met. You are the first person anyone calls and the least equipped person to answer. The ICU has 12 beds. Bed 3 is a 22-year-old from a car accident, a bleed inside his skull pressing on his brain. Bed 8 is a 61-year-old, 2 days after brain surgery, who can't remember his daughter's name this morning. You chart it. You move to bed 9. That's the job. 6 weeks in, morbidity and mortality conference. Every neurosurgeon in the department in one room reviewing every complication from the previous week. The program director runs it like a deposition. He asks you, in front of 40 people, why a specific lab was ordered on a patient the night before. You weren't on that case. You don't know. You say so. He moves on without responding. The silence lands heavier than any answer would have. A senior attending finds you in the hallway afterward. He doesn't lead with his title. He just tells you his name, call him Dr. Reeves, and explains the answer. No lecture attached. Then he says one thing. This program will try to break your confidence before it teaches you anything useful. And the residents who figure out the difference between the two are the ones who finish. Then he's gone. You come back the next day. 8 weeks in, a patient dies on your watch. A 68-year-old, 5 days post-op, a blood clot that reached his lungs before anyone caught it. You called the attending at 2 a.m. You followed every instruction exactly. The patient died at 5:40 a.m. You wrote the note in his chart. You went to check the next patient. You didn't cry. You didn't feel what you thought you would feel. The absence of feeling was its own kind of data point, and you filed it away without examining it. Your girlfriend of 2 years comes to visit on your one free afternoon in 3 weeks. She sits in the hospital cafeteria while you handle an admission that wasn't supposed to happen. When you come downstairs, she's still there. Her coffee is cold. She doesn't say anything. Neither do you. You sit across from each other and you both understand that something has shifted and that neither of you has the time or the language to address it right now. She takes the train home. You go back upstairs. End of intern year. $310,000 in debt. 26 years old. Dr. Reeves still watching you in a way that doesn't feel like surveillance. Year 2 starts Monday. Someone will call you first now. Rank 3, the junior resident. 11 p.m. your pager goes off. Emergency department. A 19-year-old headache that started 2 hours ago. Worst of his life. You know what that phrase means now. Worst headache of their life is a brain bleed until proven otherwise. You grab your badge and move. You pull up the CT scan at the workstation outside his room. You see it immediately, a white smear around the base of the brain where there should be nothing. Blood in the fluid surrounding the brain caused by a burst artery. You call the attending. Your voice doesn't shake. That surprises you for about 3 seconds, and then you're already moving to the next step. The patient goes to the ICU. You write the orders. You stay until 2 a.m. to make sure nothing changes.
Nothing does.
You go back to the call room. You don't sleep. This is year 3. You're evaluating consults, reading scans, assisting in cranial and spine cases, and managing trauma calls as the first responder. You're not the primary surgeon yet. But you're the first call at 11 p.m., and what you do in the next 10 minutes before you reach the attending determines what the attending is walking into. 3 months later, your formal evaluation lands. The program director's language, technically adequate, judgment inconsistent under pressure. That assessment goes into your permanent file and follows you to every fellowship application. You have 30 days to contest it. You don't sleep well for 4 days. You run the math on whether your career survives this. Dr. Reeves doesn't ask permission. He files a formal written challenge through the department's review process, citing your case logs and every other evaluation in your file. 3 weeks later, the assessment is revised to neutral. He tells you it's handled, doesn't explain how. You don't ask. That night, you call your dad. He drove you to MACAT prep every Saturday for 8 months, 6 a.m., before either of you was fully awake. He asks how it's going. You say fine. He doesn't push. You both stay on the line for a moment without saying anything. No particular reason. It's just the closest thing to comfort you've had in about 4 months. And somehow you both know that without discussing it. You hang up. You go back to the call room. Case count at the end of year 3. 390 operations logged. You need 1,000 to graduate. Your file is clean. The debt, $300,000. Age, 28. Dr. Reeves. Still there, and you owe him something he hasn't asked for yet. Rank 4, the senior resident. 1:30 a.m. trauma activation. Gunshot wound to the head. You are the most senior neurosurgeon in the building. The attending is 20 minutes away. The patient is 29 years old. There is blood collecting inside his skull and the pressure on the monitor is climbing. You make the call. You open him up. Find the source, control the bleeding. You make decisions you have studied and simulated but never made alone. The attending arrives, looks at the imaging, looks at your work, says 2 words. Looks right. That's it. 4 years of waiting for that. It lands smaller than anything you imagined. You go write the operative note. Boards come at the end of year 4. Written exam, first a full day of questions covering every neurosurgical scenario imaginable. Then oral boards. 2 senior surgeons in a room, no notes, and you talk through emergencies out loud in real time. Pass both or your career stalls. You study for 3 months straight. You pass both. Midway through year 5, a spine case. Routine procedure. Pre-op. The team runs a standard check patient name, procedure, location on the body. You've done this 1,000 times. You are already thinking about the afternoon case. The scrub tech says your name. Just your name. You stop. You look at the consent form. You look at the patient. Wrong vertebra marked. 1 level off. You correct it. You complete the case. 2 more cases that afternoon. That night you lie in the dark replaying where your hand was for 2 hours. More than 60% of neurosurgical residents report burnout. More than half report anxiety or depression significant enough to affect their work. Nobody talks about it. Talking means you can't handle it. Dr. Reeves misses morning conference twice in the same month. You cover for him both times. After a case last week, you noticed something not in his hands, but in how he was moving through the oar. Slower. Hesitant in spots where he's never been hesitant in 5 years. You don't say anything. You file it. Your younger brother texts you on your birthday. Family dinner without you again. He sends a photo of your parents, his girlfriend, an empty chair. Not an accusation. Just documentation. You look at it for a long time between cases. By the time you respond the next day, the moment has passed. You send a thumbs up. He sends one back. Board eligible. $280,000 in debt. 29 years old. Dr. Reeves. Something is wrong. Chief year next. Rank 5, the chief resident. You are running the neurosurgery service. 11 residents below you. 4 attendings to coordinate. 6 are on some days. You are also about to end the career of the person who saved yours. Chief resident is the top of the trainee ladder. You manage the schedule, handle conflicts, prepare conference, sit in departmental meetings on behalf of the program. You're operating 4 to 5 days a week on the most complex cases of your training skull base, cerebrovascular, complex spine. You sleep less than you did in intern year, which you would not have believed possible then. 3 weeks into chief year, after a long afternoon case, a scrub tech pulls you aside. She's been in that or for 14 years. She picks her words carefully. She tells you that Dr. Reeves has been off. Not just slow. She saw him pause mid-dissection last Tuesday for about 8 seconds and stare at the field like he'd forgotten where he was. She doesn't know who else to tell. You already knew something was wrong. You'd seen it for months and told yourself it was fatigue. There's a formal process for this. You report a colleague you believe is impaired substance use, health issue, anything that puts patients at risk through a confidential system. The report triggers a formal evaluation. If the evaluation confirms a problem, the surgeon's privileges are suspended. You file the report. He is evaluated. The finding: early-stage cognitive impairment affecting procedural judgment. Privileges suspended indefinitely, pending specialist review. The program redistributes his cases. His name stops coming up at morning conference. He calls you once, about 10 days later. He knows. He doesn't say so directly. He tells you he heard about the report and that he understands why someone felt they had to file it. He says it like he's talking about a third party. You talk for 5 minutes. That is the last real conversation you have. That night you go for a run. First time in 2 years. You run until your legs give out and you're standing on a pedestrian bridge over the highway at midnight catching your breath. You don't feel relieved. You don't feel guilty. You feel like you did the only thing available to you, and that doing the only available thing still costs something real. Those two facts don't cancel each other out. You did the right thing. Knowing it doesn't make the 5-minute phone call easier to sit with. Residency over. $255,000 in debt. 33 years old. Board eligible. Fellowship in 3 weeks. Dr. Reeves. Suspended, unreachable. His name still on the evaluation from year 3 that he fixed. Rank 6, the fellow. Fellowship is 1 more year at the bottom. New hospital. New city. New hierarchy. You unpack the same boxes you packed when residency started. You are 33 years old with 9 years of postgraduate training, and you are once again the lowest-ranking person in the building. You chose Cerebrovascular Fellowship Advanced Training in Surgery for brain aneurysms and related vascular problems. The cases are the most technically demanding you've encountered. The fellowship attending, Dr. Patel, teaches almost entirely by doing. He steps back at critical moments and watches what you do with the silence. 2 months in, a complex aneurysm case. A weak spot on a brain artery located where 3 vessels converge. The dissection requires separating the aneurysm from surrounding brain tissue under a microscope, using instruments thinner than a pen. Dr. Patel scrubs in beside you. At some point during the case, he steps back. He doesn't say anything. He just stops and watches. You finish the dissection. You clip the aneurysm. You close. Nobody in that room knew you a year ago. Nobody in that room knows what a year ago cost. The moment you train 14 years for lasts about 45 seconds of internal experience before the next case is already being prepped. That night your dad leaves you a voicemail. He thinks you graduated, that the training is finished, that you've arrived somewhere permanent. He sounds genuinely proud. He rambles about a trip he and your mom are planning, your brother's new apartment. Nothing in particular. He ends by saying he's proud of you. Just that. You listen to it twice in your car in the parking garage before going back inside. You don't call him back that night. You tell yourself you will tomorrow. The program director from your residency, the one whose evaluation nearly ended your career, has been pushed out. Not retired. Pushed. A new department chair came in and restructured the program's leadership, and he was moved out of his role in a process that took about 6 weeks and was never discussed publicly. You hear about it secondhand. You feel nothing in particular. The institution that built him eventually used the same logic on him that he used on you. Fellowship ends. First attending contract. $515,000 salary. After malpractice insurance, neurosurgeons pay $35,000 a year. One of the highest of any specialty licensing fees and loan payments. The math is real, but not transformative. Debt down to $185,000. You're 34. The voicemail is still on your phone. Rank 7, the attending neurosurgeon. 8 months in. Your name on the operative report as primary surgeon for the 200th time. The thing you trained toward for 14 years. It's a Wednesday. You have 2 more cases this afternoon. This is not disappointment. This is what it looks like when the extraordinary becomes normal. That's supposed to be the goal. You operate independently now. No one above you in that room. The residents and nurses and techs orbit around you the way you once orbited around others, and you understand for the first time what it costs to hold that position for decades without anyone acknowledging the weight. 9 months in, a patient develops an infection after a spinal procedure and is readmitted. The family contacts a lawyer. You receive a malpractice notice, a formal claim that your care caused harm. The hospital legal team takes over. You are told not to contact the patient. The case runs 16 months and resolves without a finding of negligence. You find out through a letter you read in your car in the parking structure on a Tuesday afternoon. You were not negligent. The letter says so. You already knew that. It didn't stop you from replaying the case at 3 a.m. for 16 months. A junior resident on your service misses a post-operative finding on a scan. A buildup of fluid inside the skull after surgery, putting pressure on the brain. The patient isn't reassessed until morning rounds. By then, there's permanent damage. You manage the process documentation, conference, supervise practice. The legal team handles the family. Everything done correctly. You sit the resident down. You say what someone once said to you, that the system caught it, that she needs to learn from it and move forward. You recognize the cadence of the words as you say them. You watch her face. You don't know if it reaches her. Your dad visits for the first time since you moved for fellowship. He asks to see the hospital. You walk him through it. He is quiet the whole time. Outside the main or suite, he puts his hand on your shoulder and doesn't say anything. You stand there for a moment. It is the most anyone has acknowledged what this cost in about 8 years. He flies home the next morning. You go back to work. Debt at $110,000. Salary steady. Dr. Reeves. You heard through someone that his privileges were reinstated at a smaller hospital 2 states away after a 2-year evaluation process. You don't know if that's true. You haven't tried to find out. Rank 8, the section chief. 6 years as an attending. Promoted to section chief of cerebrovascular surgery. 2 fewer operating days per week. In exchange, budget reviews, faculty evaluations, accreditation paperwork, strategy meetings that run past the time you used to be scrubbing in for afternoon cases. The operating was the part that made sense. Now there is less of it. You lead the subspecialty service now. You mentor junior faculty, oversee the fellowship programs, set clinical direction for your area. You still operate 3 days a week on the most complex cases in the department. You are responsible for every outcome in your division and for every surgeon who produces them. A second-year resident, someone you personally advocated for during the match, misses a post-operative finding. A buildup of blood inside the skull after surgery, pressing on the brain, that went unrecognized until morning rounds. By then, the damage is permanent. The family contacts a lawyer. You manage it correctly. Documentation, conference, supervised practice, legal team. Everything by the process. You sit her down afterward. You say what Dr. Reeves once said to you, that the system caught it, that she needs to understand what happened and keep going. You hear the words coming out of your mouth. You watch her face. You don't know if it lands. You won't know for years. Then the Dr. Reeves situation reaches its end, and not the way you expected. The hospital where his privileges were reinstated had him presenting cases at a regional conference. Someone from your program attended. Word got back. Then a formal complaint was filed by a colleague at that institution, political, partly, but not without basis, and it triggered a review that ended with his credentials permanently revoked. No ceremony. No announcement. An administrative process that took 4 months and concluded in a document nobody published. You hear about it from someone in your department who thought you'd want to know. You step outside after that conversation and stand in the parking structure for a few minutes. You think about the 5-minute phone call. You think about what he said, that he understood why someone felt they had to file the report. You think about whether he actually believed that. You go back inside. You implement a resident wellness program. Mandatory check-ins, peer counseling, confidential support. Participation stays low. The culture doesn't change because of a memo. You knew it wouldn't. You implement it anyway. Salary at $475,000. Debt gone. Your kids are in middle school. They know you're a neurosurgeon the way they know the capital of France. A fact. Not a thing about you. Rank 9, the department chair. And the end. Promoted to department chair 5 years after section chief. The whole department now faculty, residents, research, budget, strategy. You operate 2 days a week. It's the only part of the job that still feels real. Then something changes. Not in your hands. In you. You start avoiding the harder cases. Not consciously at first. A scheduling conflict here, a meeting that runs long there, but after 3 months you notice the pattern. The cases you would have taken without a second thought 5 years ago, the ones with the highest risk, the tightest margins, you're routing to your junior attendings. You tell yourself it's mentorship. It isn't entirely. You are 57. You've been in operating rooms for 30 years. At some point, the body starts keeping score in ways you can't override with training or willpower, and you either see it clearly or you don't. You see it clearly. You set your own retirement date. You don't wait for anyone to suggest it. You don't let the process find you. You surrender your surgical privileges, your DEA registration, your hospital credentials, the licenses that allow you to operate on another person's brain. Without them, you are not a neurosurgeon. You are someone who used to be one. The difference is not small. Your last case is a craniotomy. The same operation you watched through glass on the first morning of your rotation 31 years ago. The scrub tech hands you the final instrument without being asked. You close the layers. You step back from the table. There is a small ceremony, plaques, a framed photo of your first or team, a speech. You smile. You don't feel what you thought you would feel. You stop knowing what you expected to feel a long time ago. The accounting. 31 years. Roughly 9,000 operations. 3 patients who didn't survive who still find you at 3 a.m. A pediatric trauma from year 7. A post-operative stroke you replayed for 2 years. A routine case that went wrong in the last 10 minutes and had no good explanation. A therapist called it PTSD, where past events return as if they're happening now. You didn't argue. One relationship that ended in year 3. One that held. Children who are adults. The voicemail from your dad saved on a phone in a drawer. You haven't listened to it in years. You know exactly what he says. Somewhere in this hospital right now, a third-year medical student is on her neurosurgery rotation. She's watching a craniotomy on a monitor above the table. She sees the skull opened. She sees the anatomy. She sees the problem identified and fixed. Something happens in that room. She decides. She has no idea. She will.